Nice to meet you. I'm Go Young-jin from South Korea. Topic of my presentation is epidemiological impact of the national immunization program for varicella in South Korea. Authors declare no conflict of interest. Varicella zoster virus is highly contagious. Secondary attack rate for susceptible household contact is 60 to 90%. Varicella is one of the most common infectious diseases in preschool-aged children. Varicella vaccination has been introduced in many countries, which has led to a marked decrease in its incidence. It was also introduced in the NIP of South Korea from 2005. One dose varicella vaccine has been recommended for all children aged 12 to 15 months. Since 2010, the rate of varicella vaccination has reached more than 97% nationwide. Despite the high vaccination rate, NIDS showed that the incidence of varicella has been continuously rising from 11,000 cases in 2006 to 80,000 cases in 2017. As a result, several papers have raised awareness about occurrence of varicella in South Korea. Lee et al. Conducted community-based matched case control study, and they reported that varicella vaccine used in South Korea was not effective for preventing varicella infection. The purpose of our study was to evaluate whether increase in the number of varicella cases reported to National Infectious Disease Surveillance System reflect a true increase in the number of varicella cases by using National Health Insurance claims data. In addition, we used a series of birth codes to assess effectiveness of varicella vaccination before and after its introduction in NIP. We use NIDS and NHIS database for evaluating varicella occurrence. The NIDS is a passive surveillance system managed by the Korea CDC, which monitors incidence of national notifiable infectious disease, of which notification by physician is mandated legally. Varicella was added to list of notifiable diseases in 2005, same year when its vaccination was introduced to the NIP. South Korea has a single-payer universal coverage national health insurance scheme managed by the NHIS. The NHIS claims data contains information including medical utilization, diagnosis of patients based on ICD-10, prescription reports, and patient characteristics. Claimed varicella cases were identified based on the time of first diagnosis for each individual. We evaluate incidence of varicella using surveillance data from the NIDS and compare it to claims data from the NHIS, which is considered the gold standard for certifying the number of hospital visits to patients with varicella. For evaluating the reporting rate, we calculate ratio of these two indices, NIDS reports per NHIS claims. In order to evaluate effect of varicella vaccination on birth code, we calculate age-specific incidence and cumulative incidence rate of varicella in each birth code according to age. Age-specific incidence rate was calculated as the number of varicella claims according to age by the number of births in each birth code. Age-specific cumulative incidence rate was calculated by dividing the cumulative number of varicella claims by the number of births in each birth code, because lifelong protective immunity develops after varicella infection. The dark gray indicate NHIS claims of varicella, the light gray indicate NIDS reports of varicella, and the line indicate the ratio of the two. Incidence of varicella in South Korea showed bimodal shape depending on seasonal influence, featured observed with both NHIS and NIDS data. Reports of varicella in the NIDS system have steadily increased, but NHIS plans for medical utilization of varicella treatment gradually decreased since 2012. Since clinicians are required to report both suspected and confirmed varicella cases to NIDS, all claims related to varicella cases should be reported to NIDS. The ratio between claims of NHIS and reports of NIDS indirectly reflects this reporting rate. The ratio between two was greater than 80% since the second half of 2017. These graphs were about age-specific incidence and cumulative incidence rate according to the code before introducing varicella vaccine in NIP. The age-specific incidence and cumulative incidence of varicella in children born between 2001 and 2006 is similar. Age-specific incidence rate in children aged 4 to 6 years decreased about one-third in birth cohort born after 2009 compared to those born before 2005. Almost 27% of all babies born before 2005 were diagnosed with varicella at least once before 6 years of age. However, the cumulative incidence rate of children born after 2009 was approximately 11%. This reduction was likely to be the effect of vaccination. The delayed incidence reduction after introduction of varicella vaccination was due to the length of time from vaccination to school age and varicella vaccination rate. Since age 4 to 6 is when a majority of varicella cases occur, it takes at least 4 to 5 years to reduce occurrence of varicella after vaccination. Also, the vaccination rate rose gradually until 2009. The vaccination rate of varicella in 2007, 2008, and 2009 was 78, 89, and 99% respectively. In the United States, it took 4 years to reduce the incidence of varicella by half after varicella vaccination was recommended. Our study has some limitations. First, our study did not evaluate association between individual vaccination history and the occurrence of varicella, so we could not directly estimate the effectiveness of vaccination. Second, it was not possible to determine whether the varicella cases were due to breakthrough infection after varicella vaccination. Claims data did not include information about disease severity. Third, since the incidence rate was defined as the number of varicella cases relative to the number of births in each birth cohort, it did not reflect change in population by age due to deaths or immigration. However, South Korea has not been affected by any sudden population changes in recent years. In conclusion, the incidence of the increase of the reported incidence of varicella in South Korea was inconsistent with the insurance claims data, which suggests improvement in reporting rather than true increase in incidence. The varicella incidence in the post-vaccination birth cohort was reduced compared with the pre-vaccination birth cohort. Further confirmative studies such as field trial are needed to assess the effectiveness of varicella vaccination. Thank you for attention. Yeah. Do you have any question or comment?
I guess what's the efficacy studies your vaccine vaccinations efficacy, in RCT studies results? How effective?
Efficacy in varicella vaccine in South Korea is similar than other countries, about 70 to 80%, and it's not high but efficient.
I thought that was a terrific talk. One of the questions I had was in the National Health Insurance database. You had mentioned that you evaluated varicella based on an ICD-10 code. Could you comment just on the validity of that, and in particular the validity of the ICD-10 code for varicella in your data source? And in particular, I noticed that you had mentioned that you were getting data from the Korean Centers for Disease Control, and at some point you mentioned that approximately 80% or so of the ICD-10 diagnoses were also identified in the CDC. Can you just comment on that and whether potentially the reports to the CDC would be considered a gold standard?
I think claims data in NHIS is golden standard. Varicella is reported to NIDS since 2005, but its reporting rate is not high. It's mandated legally to physician reporting, but the physician was not reported to this. So nowadays, reporting rate is higher. So these two ratio of these two is more higher.
I guess what I was thinking was that if the data from the CDC is gold standard, that the CDC had confirmation, potentially you could report separately that if more than 80% of the diagnosed individuals were confirmed by the CDC among those who had data in, that's very reassuring on the validity of your varicella diagnosis, and maybe even something that you could write up separately as a validation study for going forward. Other questions?
Thank you.
The topic of my presentation is incident rates of healthcare outcome of interest among Chinese children exposed to selected vaccines. Prospective or is a population-based retrospective cohort study. For background, electronic healthcare databases provide real-world evidence with broader patient populations. It has been used widely past 2 decades in US as well as Europe. Some examples such as Sentinel in US and Protect in Europe. EHDs in China have been rapidly developing and growing. There are 3 types of EHDs. The first is EMR in hospitals, national claims database, and the last one is population-based community EHR. There is a growing interest to evaluate and understand those EHRs in China. One of the main purposes for our study is to evaluate the Chinese EHR, community-based EHR. Just for background, for those who don't know about practicing vaccines in China, there are 2 types of vaccines in China, type 1 and type 2. Type 1 vaccines are mandatory and provided by Chinese government free of charge. Type 2 vaccines are voluntary, and people have to pay out of their own expenses. One thing is different between U.S. and China is that in the U.S., children go to pediatric offices or hospital clinics to be vaccinated. But in China, all vaccines are vaccinated in CDC immunization clinics. So this study is a retrospective cohort study using existing data sources, which is YINZHOU, EHR, a community-based EHR. Children 0 to 2 years of age receiving at least one dose of vaccine of interest in this study, OPV, DTP, HIP, and Pentaxin. I just want to point out OPV and the DTP are type 1 vaccines in China, and HIP and Pentaxin are type 2 vaccines. Children must be, in order to be eligible, they have to be in the database, has one record between January 1st, 2012 and March 31st, 2017. We use ICD-10 code to identify health outcome of interest. We estimated incident rate per 100,000 person year at risk, and per 100,000 doses. Then the risk period is 0 to 7 days and 0 to 30 days after exposed to those vaccines. YINZHOU is one of the largest districts in Ningbo City of Zhejiang Province. It has approximately 1.8 population. YINZHOU started to collect health records of its residents since 2005. By the time 2008, it covers all medical care encounters of its residents within the district for the hospitals as well as community centers. So YINZHOU gets its data from 4 resources. The first is inpatient, outpatient care in the hospitals within YINZHOU district, which is 5 hospitals. And second would be community health centers, so that would be outpatient care, 24 healthcare centers. And then they also get the data from CDC, including 2 databases. One is the immunization administration registry, and another one is AFR. The last data source is from Women and Children's Hospital in Ningbo City. So that is the only the children's hospital in Ningbo City. So nearest one would be 2 hours drive. So if there's any severe disease occur, most likely the children would go to the Women and Children's Hospital for care. So this is a result of our study, and we included 220,422 children. The average age at the time entering study, it's about 2 months. So 53% of those children, females, and residential status, 76% are temporary residents, which is defined by their parents are not originally from Ningbo City. So In terms of, this table shows the incident rates and the 95% confidence interval of health outcome of interest per 100,000 person year at risk within 7 days after vaccination. Because the results within 30 days are having similar trends, so I'm not going to present results here. Or just focus on 0 to 7 days post-vaccination. We didn't find any case of apnea and GB syndrome within 30-day period, and we did identify 2 Kawasaki disease for DTP between day 8 to day 30 post-vaccination. So it looks like HIP has a higher incidence of seizure, anaphylaxis, and urticaria, and angioedema. Pentaxine has a higher incidence of febrile seizure, and DTP has a higher incidence of wheezing and asthma. Comparing to the literature, so literature has limited data in children. So especially when we couldn't find any data in Chinese children in a similar age. However, we find the incidence of all seizure for DPT is comparable to that in the public literature in US and the European population. The rest of the health outcome of interest, the results are different from those in the literature if it's available. It's either higher or lower. That's because of different study design, and they have different study populations. Some of the studies include children 0 to 15. And also other studies designed prospective cohort studies, so of course they would have a higher incidence. For the database study, we only found one using Chinese database, database that study is published about 10 years ago, 15 years ago, that's in Hong Kong. So that incidence would be higher than what we report here. This table shows incident rates and the 95% confidence interval per 100,000 doses within 7 days after vaccination. It's very similar as per 100,000 person year at risk. HIP has a higher incidence of all those events, 5 events of healthy outcome of interest. Compared to published literature, for this we have more literature in to compare. However, we still don't find the data in Chinese population and also in the same age group. We could find some data in US and European population. Oh, sorry. So for DTP, still there for seizure and anaphylaxis, the incidence are comparable. The rest are either higher or lower, as I mentioned before, because of different study design, different study population, and data sources used for their studies. So we would like to conclude the incident rates, like I mentioned before, some health outcome of interest identified in YINZHOU EHR database were comparable with that in the literature, where others are not, because of the reasons, different study designs and different data sources and study populations. We conclude that YINZHOU EHR has promise as data source for vaccine safety surveillance, despite some limitations. The one limitation, the two key limitations. The first one is because they have, like I mentioned before, they have 76% of temporary residents. So those, because the data is linked by national ID, which is unique to each system, each citizen in China. So some those children from temporary resident do not have a national ID yet. So we couldn't link their database. We tried to link their database by date of birth, link their data by date of birth and their residential address. But still, there are small percentage of those children we couldn't link their healthcare record. And the second is that the ICD code version we use is 2017 version, but the study period is 2012 to 2017. So the prior version we don't have it because the YINZHOU CDC also don't have. So that is I know there's some changes during that period of time in terms of ICD version. The feedback from the YINZHOU CDC, the database owner, is that they should have no impact on the outcome, health outcome of interest we evaluate. So we suggest a further study if they are going to use YINZHOU CDC for vaccine safety study. The validation of ICD codes against the medical charts is important. So that will help to better understand potential misclassification using or undercoding for because of using ICD-10 codes. I would acknowledge my co-authors. Thank you.
Hello, my name is Zhang from South Korea. Thank you for your presentation. In your limitations, you said that 76% of the residents in YINZHOU are temporary residential people.
Yeah.
Then that's more than 3/4. Then would the results of your study be a good representative result of the original YINZHOU district?
Yeah, I think, okay, so your question is that because majority of the children in the study are from residents, temporary residents, but it doesn't mean they move within like 1 or 2 years. That means they migrated, their parents migrated from other part of the country. Ningbo is a city, basically it's a migration city. The majority, I think, would be 30% of the population are permanent resident. The rest would be the temporary resident. But the challenge, because of temporary resident, you need to understand Chinese, the national ID system, because you have to go back your parents' origin city in order to get the national ID. So the children cannot get a national ID in Ningbo. So this is why there are some children, I think it's about 6% of the children, they can't be linked. Their medical records cannot be linked, but they may have those events. If they have those events, that will affect the results of the study. Yeah.
Questions? My name is Yang from GSK Vaccine. I have a question. Basically, the data was extracted from 1st of January 2012 to the 31st of March 2017. So my question is how this interval was determined, and was it linked with the introduction of the vaccine?
The data, YINZHOU started collecting data in 2005. So by 2008, they covered all the hospitals and community health centers. We think the data between 2008 and 2011 2011 may not be as optimum as after 2012. So this is a period we pick. This is why it's this is original. This period we think there's some messy data.
Okay, I try to articulate here. Just a question out of curiosity. One of the data sources is Mother and Children Hospital, and I was wondering if in this database system there's a mother-baby link in terms of data. If you look at, for instance, studies of maternal immunization, you want to look at the offspring of vaccinated mothers.
I'm so sorry, I still have a hard time hearing you.
I'll try again. You said one of the data sources is the Mother and Children Hospital, and I was wondering if there's any in terms of linkage, if there are mother to baby links in those data sources in order to do studies, for instance, of looking at the offspring of vaccinated mothers. Was that better?
So if I understand your question correctly, so there's one of the data sources from Women and Children's Hospital, yes. Right? So you want to see what, so I still didn't hear the rest.
Is the data for mothers linked to the data for babies?
Yes, they are.
Okay. Thank you.
There are more than 10 kinds of type 1 vaccines in China. But why do you select DPV and OPT for your research?
So, type 1 vaccines.
Yeah. So there are more than 10 kinds of type 1 vaccines in China.
Yes.
Why do you select OPV and OPT?
Okay, so why I pick those two, right?
Yeah.
Okay, so because in order, as I mentioned at the beginning, one of the main purpose of our study is to evaluate YINZHOU EHR database. So we think the steps we want to, for type 1 vaccine, why we pick those two? Because those are, we think the coverage will reflect the quality of the vaccine data. So actually the coverage of those two OPD for OPV is 98.3%, which very close to the one already published data for Zhejiang province. And DPD is also very close to the published data. So that means the CDC data, at least in terms of capturing type 1 vaccine, is very good, is optimal. And then for type 2 vaccine, we picked HIP and Pentaxin. That's because of the coverage. We cannot pick too low the coverage. Based on the literature, Pentaxin vaccine, the coverage is about 8%. So our coverage is very similar. It's about 9%. For HIP, literature is about 20%. So for YINZHOU, it's 18-19%. So it's very close. So in terms of vaccine data or CDC data, we think it's optimal. Yes. Thank you.
Good afternoon. My name is YINZHOU, and my research topic is prescription patterns of anti-diabetic medication during pregnancy in South Korea. Use of medications and complications during pregnancy are important on maternal health and fetal development. Although medication use in pregnancy has grown over the past decade, pregnant women are still in the state of therapeutic orphans. Moreover, as pregnant women are generally excluded from clinical trials, information of drug use in pregnancy is lacking. GDN, one of the most common pregnancy complications, is known to increase the risk of congenital anomalies and other adverse pregnancy outcomes. As the prevalence of both pre-existing diabetes and GDM are steadily increasing, it can be inferred that more women are using anti-diabetic drugs before and during pregnancy. Despite this current situation, research exploring this issue is limited. The objective of this study was to evaluate the utilization of anti-diabetic medications during preconception and pre-pregnancy period based on maternal characteristics. This study was conducted using National Health Insurance Service National Sample Code Database of South Korea, composed of approximately 1 million people that were randomly extracted from entire Korean population. Database characteristics are as shown, where patient characteristics, diagnosis, prescription, and medical procedure information are included. The study population was pregnant women aged between 10 and 49 years who had an overall birth. For pregnancy definition, a procedure code for delivery was used. This is a scan for preconception period, first, second, or third trimester. Delivery date was the date that a procedure code appeared in the database. Gestational day 0 was defined as 208 days prior to the delivery date, and gestational period was defined as from day 0 to delivery date. Preconception period was defined as 1 year prior to day 0. First trimester was day 0 to 90, and the second or third trimester was day 91 to 273. Medication prescribed within 7 days before delivery were excluded from our study as their prescription patterns were likely to be changed for delivery purposes. Drugs of interest were oral anti-diabetic medications, including insulins and oral anti-diabetic agents. Combination products were also included, and each drug ingredient were considered individually. For statistical analysis, we identified and compared characteristics between anti-diabetic medication users and non-users. Maternal tract care test was done to determine statistical significant difference between the two groups. The prevalence of anti-diabetic medications was stratified by the following maternal characteristics: years of delivery and maternal age, insurance type, income level, residential area, and medical institution types. Table shows the comparison of characteristics between any anti-diabetic drugs users and non-users. Of a total of about 80,000 deliveries, 428 deliveries were prescribed with anti-diabetic medications. Diabetic medication users had a higher proportion in those in their 30s, medical aid beneficiaries, living in urban areas, having prescription of antihypertensive drugs before and during pregnancy. The green box in the table shows the number of pregnancy episodes prescribed anti-diabetic medication for each term. In the preconception period, metformin was the most commonly used with 63%, followed by sulfonylureas and insulins. In the first trimester, metformin was the most commonly used with 44%, followed by insulins and sulfonylureas, while that in the second or third insulins with 93%. Figure to show a secure pattern of anti-diabetic medication. There was an overall increasing trend for oral anti-diabetic medication in all periods. In the year before pregnancy, metformin showed the highest number of prescriptions, and for the first trimester, insulin prescriptions was suddenly increased in 2011. For the second or third trimester, a sharp increase was observed, and it seemed that insulin is used the most. Anti-diabetic medication use increased with maternal age, especially in women aged between 35 and 44. Medication use doubled in the second or third trimester compared to the pre-conception period, while there is a little change in the younger age group. Medical aid beneficiaries use more anti-diabetic drugs than those who have health insurance. Also, medication use was increased with income level and were more prevalent in pregnant women living in urban areas. Overall, prescription of anti-diabetic medication decreased in the first trimester but increased in the second or third. In the first trimester, medications seem to be used more carefully. However, as all mothers are screened for GDM in the second trimester, it is natural that GDM treatment increases accordingly. Also, medication use increased with income level and was more prevalent in urban areas. It may be because women with high income and those living in urban areas have a higher chance of getting medical examination before pregnancy, hence more likely to detect GDM. In the first trimester, metformin was the most commonly used, and while that of in the second or third was insulins. Amongst oral anti-diabetic agents, or but metformin was not recommended during pregnancy, but our research showed that non-recommended anti-diabetic drugs were used more in the first trimester than in the second or third. Compared with other countries' results, prevalent use of anti-diabetic drugs in Korea was lower than the US or Europe. Strength of this study was that this is the first study to have described the patterns of anti-diabetic drug use, including all anti-diabetic medications, among pregnant women in South Korea. For limitations, the drug use should not be interpreted as the actual use due to the non-compliance, and there exists the risk of misclassification as preterm and postpartum births were not separated. In conclusion, of total deliveries, 0.52% deliveries prescribed with anti-diabetic medications. Anti-diabetic drugs used in Korea was lower than that in the US and Europe. Non-recommended medications were more commonly used during the first trimester than the second or third. Our findings warrant the necessity of rational medical use in early period of pregnancy. Thank you for your attention.
Given that you found that in the first trimester there are some non-recommended anti-diabetic drugs, what would you suggest going forward as potential interventions to prevent the use of those drugs in the future based on your data?
Could you please repeat the question?
Yes. Given that you found in the first trimester some anti-diabetic drugs were prescribed that were not recommended, is there a recommendation of how to avoid their use in the future?
We know this drug have a lot of the adverse effect on pregnancy women. This drug is not very good for pregnancy women. Those drugs are not very good. It's bad. So in the future, maybe your study can tell us that we don't need this drug. The question is, we don't need this drug. How do you have any idea or any study maybe mention something like this? That's the question.
I think I will answer. I might answer. Yeah, maybe in South Korea we have computerized system to detect contraindicated drugs for a pregnant woman, but very early stage, maybe woman would not know they are pregnant or not. Before the prescribing, if they have diabetes and they might prepare the pregnancy, I think we might have some risk management program or something systematic policy or yeah.
So yeah, as Pete said before, that we looked at developmental outcomes in children aged 4 following maternal anti-epileptic drug use. So what do we know about the effects of prenatal anti-epileptic drug exposure on children? Well, there's a 2 to 3-fold increase in the risk of major congenital malformations, and more recently they've found evidence of long-term neurodevelopmental effects following maternal use of sodium valproate. So in New Zealand we don't know the true burden of those neurodevelopmental effects or the burden within New Zealand. So we aim to conduct a database linking cohort study to investigate whether prenatal anti-epileptic drug exposure was associated with adverse outcomes in our before-school check assessments, and there's particularly looking at the assessments measuring neurodevelopment. So in New Zealand we've got a lot of administrative databases, and we used encrypted identifiers to combine 3 of those databases. So that was the National Minimum Data Set, which is our hospital discharge data, and that captures about 97% of the births in New Zealand. And we used the pharmaceutical collection, which is all community dispensed medicines, and in New Zealand this captures most of community dispensed anti-epileptics. And then we also combine this with this before-school check database, and I'll talk a bit more about that database. And we analyse this data, and we compare baseline maternal and study population characteristics using the Pearson's chi-squared, and then we did logistic regression models, and we estimated adjusted risk ratios. And we adjusted these on ethnicity, gender, and socio-economic information. So this is the before-school check database. It was rolled out in New Zealand in 2010, and it's gained coverage, but it's always been very high coverage, and it's particularly high now, so it captures over 90% of all eligible 4-year-olds. And then it's offered to, nurses do the assessments in different settings depending on the community, so they can be at the family doctors, clinics, or nursing clinics. And it assesses a number of childhood development domains, so it looks at hearing, vision, physical development, and emotional development, and height and weight. So for the hearing, they do audiometry and tympanometry, and they do visual acuity tests for eyesight, and then they use a appearance evaluation of developmental status questionnaire to look at development, and it asks general questions about behaviour, speech and language, and motor skills, and depending on the number of concerns identified, children are assigned to pathways A, B, C, D or E, and pathway A is 2 or more significant developmental concerns. And then we also have the strengths and difficulties questionnaire, which is a brief questionnaire that assesses emotional and behavioural development, and it looks at 4 domains of childhood development, so it's peer problems, conduct, hyperactivity, and emotional problems. And then those are all scored, and a total score of 17 or higher is abnormal. So table here shows
cohort. So we had 606 children exposed to antiepileptics, and then we had the rest of the cohort there. And then so the gender distribution was similar across both groups, but children exposed to antiepileptics were more likely to be European or New Zealand only than the other ethnicities, and they're also more likely to be living in the more deprived parts of New Zealand. So on the left-hand row here, we've got the assessments, and then we've got the children not exposed to antiepileptics compared with children that were exposed. So across pretty much all of the domains, particularly the domains that assessed neurodevelopment, they had higher risk of having being referred through pathway A or having an abnormal SDQP score. And then, but with hearing, they weren't more likely to be referred for hearing or vision, but they were more likely to be already under care in those domains. So this is looking at sodium valproate monotherapy, and that's compared with Lamotrigine and carbamazepine monotherapy. So initially it's compared to children unexposed, and so that shows a higher risk of already being nearly 3 times more likely to be under care in the PEDS domain, and then much more likely to have an abnormal SDQP score, and particularly with concerns around conduct. But actually compared to Lamotrigine monotherapy and carbamazepine monotherapy, we didn't find any significant differences. So this is just the same table here, but looking at Lamotrigine and carbamazepine compared to children unexposed to antiepileptics. So actually Lamotrigine was also associated with increased risk across a lot of the SDQP questionnaire. Carbamazepine had individually higher risk in the individual domains, but not as a total, like the overall score. And then this was looking at antiepileptic monotherapy compared to antiepileptic polytherapy. So we only had 57 children exposed to polytherapy, and those children were much more likely to have abnormal SDQP scores right across all parts of that, and then they were also more likely to have hearing and vision, or they're more likely to be already under care for hearing and vision. So this study, we found that prenatal antiepileptic exposure increases the risk of developmental concerns being identified in our screening program, and exposure to AED polytherapy and sodium valproate and Lamotrigine monotherapy were associated with the highest risk. And these are just my acknowledgements, so thank you to the University of Otago for my doctoral scholarship and my wonderful supervisors and the travel grant company. Thank you.
Thanks for your wonderful presentation. I'm a pharmacist from West China Second University Hospital. My question is, since there are many other cohort and oral registry studies that also focus on the anti-epileptic drugs during the pregnancy and their influence on the babies. So, what did you suppose your study will act on in this area when you first decide to do the study? Thank you.
So I think is your question, why did we do this study when a lot of other people have
since
done?
there are many other studies have already done.
Yeah, that's a good point, and that's totally true. So globally there's plenty of studies that show the same thing, but we don't have any in New Zealand so far. And also we have this particular database of children assessments, and we thought it's actually currently underutilised. It's quite a new resource. So this almost speaks, the assessments really are before any kind of formal diagnosis parents picking up concerns sort of, and they might even be like below, they don't end up being diagnosed with anything, but they've still got this risk of having unusual sort of abnormal behaviour. I guess that's its point of difference.
Hello, my name is Nick. I'm a pharmacist and health outcomes researcher at the University of Rhode Island in the United States. I had a question. In your database, are you able to account for prenatal vitamin use and folic acid during pregnancy and before pregnancy? And if you can't, how would that affect the results of your study? Thanks.
Yeah, that's a really great point because actually there's plenty of data now to show that it does have a protective effect for women that are taking antibiotics in pregnancy. And in New Zealand, we do have the national data that will capture some of that use, but then also a lot of women buy folic acid over the counter, and that is not captured by the database. So we probably could have looked at that data, but it would definitely, I don't know the numbers, but it wouldn't be covering probably even half, because a lot of women would just buy vitamin packs with other vitamins, and it comes into, they don't have to be prescribed on top of that.
So the topic today is about the infant antibiotic use and the risk of childhood asthma. Antibiotics are the chemicals produced by microorganisms that kills or inhibits the growth of another microorganism. There are several types of antibiotics, and the most common one we are talking about is the antibiotic bacteria. So antibiotics are widely prescribed in children, and we know that about half of the children, they receive their first course of antibiotics during the first year of life. Although antibiotics can be life-saving for those children who suffer severe bacterial infections, and studies have shown that a significant portion of antibiotics prescribed are considered as unnecessary. And we know that overuse of antibiotics increase the risk of bacterial resistance, and also is associated with the risk of a series of several types of health-related concerns. So one of the such concerns is asthma. Early life antibiotics use alters the developing microbiome, reduce the diversity and relative abundance of the gut microbiota, and thus is associated with an increased risk of childhood asthma. However, the effect of timing, spectrum, and cumulative exposure of antibiotic use during the first year of life on the risk of childhood asthma is not known. So the objective of the study is to determine whether timing, spectrum, class, and cumulative exposure of antibiotic use in infancy are associated with an increased risk of childhood asthma. We conducted the study using a respective birth cohort with singleton birth, term, nominal birth weight, and otherwise healthy children born between 1995 to 2003 and continuously enrolled in 10 care. Antibiotic administration is captured during the first year of life, and we detailedly captured the number of total courses infants received, and we documented the time, the infant age when they received each course, and particularly the first course when they exposed to antibiotics. And we document for each course the spectrum, their class of antibiotics used. Childhood asthma was determined using the asthma-specific healthcare encounters and asthma-specific medication use by age 6 years. So this is the busy table, and we have in total 152,622 children. About 80% of children, they ever used antibiotics during first year of life. So compared to those children who never received antibiotics during first year of life, those who received at least one course, their mothers are more likely to be smokers during pregnancy. They are more likely born to be by C-section, more likely to be boys, Caucasians, and more likely to experience bronchitis, healthcare encounters, and more severe healthcare encounters, such as hospitalization. And they are more likely to be the first baby in the family. This is the figure shows the relationship between the antibiotic course and the risk of childhood asthma. So the x-axis here is how many courses they received during the infancy. And from 0, we kept at 8 and plus. The y-axis is the predicted probability of having childhood asthma. We can see that the black line indicates that the more courses infant receive, the higher the risk of developing asthma. And the gray area, that's the 95% confidence interval. Here we examine the relationship more detail. We count the number of courses at the infant age in months. So we look at starting from less than 1 month old to 12 months old. We count how many courses each infant received at particular month. So infant can receive 0 courses, 1 courses, or more than 2 courses. 2 and more courses in each particular month. And the dots and the lines in the figure, that's the adjusted odds ratio and corresponding confidence interval. For each particular month, never received, that's the reference. And compared to those reference, we can see that the receipt always increase the risk of having childhood asthma, and the more courses you receive, the higher the risk of developing asthma. The number here is how many people in each category and the corresponding proportions. When we limited to the population, to those infants who received at least 1 course, and we examined the relationship to say, does your age receive the first course matters? And we can see that when we adjust for how many courses infant receive at the first course, the age at the first course does not matter. We then look at the class of what type of antibiotics infants receive, whether that has differential risk. So here we classify those infants who never receive antibiotics during first year of life, those who receive only narrow spectrum plus antibiotics, those who only receive broad spectrum antibiotics, and those who receive both narrow and broad. And here is again compared to those never received, receipt of antibiotics increase your risk of developing asthma, but there's not much difference between the classes. This is more detailed classification of the type of class infants received. So never received those first generation, second, third generation of cephalosporin, macrolide, penicillin, sulfonamide, and here's the last. We lump all the others together, and we see similar pattern. Receipt of antibiotics increased risk compared to never received people, but across classes, not much difference. So in conclusion, infant antibiotics use increase the risk of childhood asthma, and the relationship is dose dependent. The more courses infants receive, the higher the risk. Receipt of antibiotic itself at any time increase the risk, and when received does not matter that much. And timing of the first course does not matter much too. And also lastly, the spectrum and the class of antibiotics have no differential effect on the risk of childhood asthma. And thank you.
What about the effect of some of the confounding factors on the association between this antibiotic usage and the asthma? The confounding variables, like maybe the mother and father could have asthma, or some other factors which may cause the asthma other than the antibiotics. So what about the effect of those factors on the asthma here?
You mean the other risk factors?
Yeah.
So we do adjust other factors, risk factors for asthma. I didn't show it here, and we adjust like the one I show here, like C-section, like how many baby in the family, like whether mom have asthma or not, representing a marker of genetic predisposition. Yes, we do adjust in the model, and results are not. That's what the results are showing here.
I have a question. Could you just clarify how long did you follow the infants through till? You mentioned that the outcome was in asthma at 6 years, so was everybody followed through 6 years?
Yes.
So just from a design decision, an analytic decision standpoint, I noticed that you used logistic regression. Why did you choose to use that in, for example, time to management analysis or alternative analysis?
So asthma is first we follow everyone to age 6 years, and asthma is ascertained between age 4.5 to 6 years. This is because before that, many people they can be transient wheezer, so they can have ICD-9 or ICD-10 codes for asthma, but they actually they basically just temporarily have the asthma symptom, but won't disappear. So we define asthma between 4.5 to 6 to avoid transient wheezer. That's one thing. And second thing is that because we use the Medicaid, the administrative database, we don't have exact timing. All we have is that when they go to see doctor, and they go to see doctor to say, I have that ICD-9 code indicating they have asthma. So we are more certain, basically, they have asthma. And we don't know when, the first time we classify they have asthma. So we don't think the survival analysis is the best approach here.
Do you have any data on the validity of the ICD-9? I know you said ICD-9 alone or ICD-9 plus anti-asthmatic treatment.
Yeah, so this study the study period is from 1995 to 2003, so in US that's ICD-9 only. And the asthma definition actually we validated in the study cohort, and it's I think it's very sensitive and specific. Both are over 90%, and also the algorithm we used is very consistent with other studies using similar database. So we are very comfortable with our algorithm.
Do you have any sense of positive value for them? Why?
No,
I'm just asking because usually, many of the validation studies will go positive value, but we only want positive value to at least have to be above 80% to have reassurance that the identified events are true outcomes.
Yeah, so the validation study was conducted, I think we published in 2001, and don't quote me on that, I think that we only reported the sensitivity and specificity, and it's probably 94% sensitivity and 97% specificity. We didn't, I'm pretty sure we didn't report the PUE.
Other questions?
Okay.
Yeah, I just wanted to know if you could get a sense of what the indications were for the antibiotic use. Are we talking about ear infections or respiratory things, or did you not have a sense of that? Thanks.
That's a good question. So I think that, so I showed you that the users are more likely to have bronchitis health encounters. So actually, bronchitis itself is an indication. I mean, logistically, bronchitis, majority of the bronchitis is viral induced and should not use antibiotics. But what our validation study actually, many bronchitis healthcare encounters do use antibiotics. And I think that otitis media is one of the most common ones besides bronchitis, pneumonia, and I don't recall the others, but those are the most common ones used. And I didn't show you the results. We do we did a subgroup analysis. We exclude all those indications. So we did exclude all those indications related to those subjects who never had those indications, and we repeated the study, and results are consistent. The sample size is much smaller. We have only 40% of the children. But it is our concern to say whether it's antibiotics or it's the infection itself increase the risk of childhood asthma. We believe probably it's both.